Good morning, everyone, and welcome to this morning's first session of the final day of the ISRRT conference, radiotherapy theme session. So I'm looking forward to 6 talks this morning. So whilst it's morning for many of you, it's also afternoon and evening, as it is for me in Melbourne, Australia. And my name is Nigel Anderson. I'm the Principal Research Radiation Therapist at the Peter MacCallum Cancer Centre in Melbourne. And I'm your chair or co-chair this morning with Jessica Mulfold, who's on the other side of the world over in Dublin. So I'm going to hand over to Jessica now. But before we do, I just want to encourage you all to ask questions in the Q&A component of the platform, which then once we get to the final part of the session this morning, you'll have an opportunity for those questions to be forwarded onto the presenters to be asked and answered, which they'll be all jumping back in at the other end of the session. So now I'm going to hand over to Jessica to introduce herself and also our first speaker of this morning's session. So thanks once again for joining us.
Morning, everyone, and as Nigel said, welcome to the second day of the Congress. I am a senior radiation therapist in St. Luke's Radiation Network in Beaumont and also the Dublin Radiation Therapy representative on the IIRT Council. So I think we'll get started. So our first speaker this morning is Ms. Francesca Cavallo of the PMC Hillman Cancer Centre in Villa Maria, Italy, and she will be discussing multiple brain mets, the impact of patient positioning errors on Cancer Centre in Villa Maria, Italy, and she will be discussing
asked and answered.
multiple brain mets, the impact of patient positioning errors on optimal PTV margin strategy.
Good morning, I'm Francesca Cavallo, and today I'm going to talk to you about multiple brain metastasis and in particular on the impact of patient positioning errors on optimal PTV margin strategy. I will start with a few words about brain metastasis radiotherapy management. In the last few years, in fact, we have seen a gradual shift away from whole brain radiation therapy strategy to stereotactic radiosurgery. SRS is now the recommended treatment for multiple brain metastases from 1 to 4 with an equivalent survival, but a lower risk of long-term neurocognitive decline compared with SRS plus BRT. Also, some studies have confirmed that this strategy is also safe for more than 5 brain metastases with the same outcomes in neurocognitive decline terms. When treating the multiple brain metastasis with a frameless linear accelerated based SRS, typically we have one isocenter for each lesion. We can use both DCA or VUMA techniques, and the treatment lasts about 20 minutes for a single lesion, 2 hours for 5 to 10 brain metastases. When you use a single isocenter, multiple targets SRS technique, usually one isocenter is placed for multiple lesions and it's located at the geometric center of all lesions. We can use also in this case DCA or VUMAT techniques, and we also have dedicated softwares that can calculate everything. And a treatment lasts about 20 to 40 minutes to treat from 5 to more brain metastases in a single session. But we have poor data about repositioning accuracy in those kinds of treatments, and in particular on targets coverage related to rotational and translational deviation of the plan isocenter. It's DCA SRS treatments, and we focused on the evaluation of target positioning accuracy, and also on risk assessment of compromised target coverage due to this. Everything, and we focused on the evaluation of target positioning accuracy, and also on risk assessment of compromised target coverage due to residual isocenter errors. In our study, we considered 31 consecutive patients, 18 years old, with 204 brain metastases, with maximum size under 3 centimeters, receiving single isocenter multiple targets DCA SRS. All plans were created using a treatment with also a 6 degrees of freedom count. And also the accuracy of setup and interfraction patient repositioning was assessed by exotrack radiograph 6-dimensional image system, and risk of compromised target dose coverage was evaluated. About the positioning system, we used SRS thermoplastic dedicated mask, and we acquired a CT scan of 1.25 millimeters like thickness. Patient setup was automatically obtained, acquired 2 stereoscopic X-ray images. So we used a software to make a match between these X-rays with DRRs generated from the simulation CT to detect setup errors and correct them directly. Then we acquired another set of X-ray to confirm the accuracy of the isocentered position. Those kind of shifts was repositioned. After X-ray verifications, we acquired also a KD beam CTs to assess offline the accuracy of those distribution in the target columns. And during the treatment, we also acquired stereoscopic radiograph imaging at different times to verify and correct the isocentered position. The accuracy of target geometry and dosimetry was evaluated using an AI software, where the beam CT was fused online to the planning CTs. And after applying the residual isocentered translation and rotation we detected with the beam CTs, the BU95 and the D95 were assessed for each target. The BU95 data were categorized at level above and below 95%. As you can see in this slide, in the image on the right, you can see a little deviation of doses in a very peripheral lesion due to residual shifts of isocenter. And this is the corresponding DVH. So we can see in the table the mean shift for each axis. So for translational axis and also for rotational ones. And you can see there are very small values, but if you look at the figure 2, you can see that very peripheral lesions are more influenced by those kind of shifts in the dose coverage. As a result, as a consequence of plan isocenter residual error, we have a loss of target coverage occurred in 28 PTVs, so 10 patients. Using a 1 millimeter GTV to PTV margin, adequate dose coverage was maintained for all lesions. So, single isocenter multiple target TCA SRS represent a fast and effective approach for patients with up to 10 brain metastasis. And the use of a robust and accurate in-treatment room 6D imaging system like ExoTrack or beam CT allow us to have very low residual translation and rotational errors on target coverage. So a GTV to PTV margin of 1 millimeter is recommended because it's enough for us. So thank you so much. If you have any other question, you can write me anytime. Thank you.
Thanks, Francesca, for a wonderful talk. Next up, we have Francesca once again, speaking a little bit further quarterly from where we started in the brain metastases, and this time down to the prostate, where Francesca will give a presentation on offline adaptive radiation therapy for prostate cancer using daily CBCT and deformable image fusion for correct replanning. Thanks, Francesca.
Good morning, I'm Francesca Cavallo, and I'm very delighted to share our experience with adaptive radiotherapy communities and deformable registrations with you all. This work is the result of a strict collaboration between two cancer center radiation therapy staff in Italy, UPMC San Pietro and UPMC Villa Maria. In experience of what happened to San Pietro Center, we have treated more than 4,000 patients in 6 years, of which around 29% with a primary diagnosis of prostate tumor, so a very high percentage. Our IGRT protocol expected a daily community for prostate patients. Images are acquired and evaluated online by radiation therapists and then approved during offline review before the next session by the radiation oncologist. As you know, in order to treat prostate and safeguard organs at risk, we can have some issues due to setup errors, anatomic changes of variable fillings that can cause organ motion. When setup images are too different from CT scan and we cannot when asked for replanning, but